Yeah, so now it's the right side of the heart, and it was also called hypoplastic right heart syndrome, but I personally do not use this term because it's not very well defined as the hypoplastic left heart syndrome. Let's call it the small right ventricle. Actually, we have two conditions which lead to a small right ventricle. Either the inflow is obstructed, which is typical condition with tricuspid atresia, in general with VST. The other one is the outflow is obstructed, similar to what we have seen on the left side, but in this case, it's pulmonary atresia with an intact ventricular septum. Now, if you know that pulmonary atresia with the VST, we have seen, looks like tetralogy of Fallot. It is not associated with the small right ventricle only, where very, very few exceptions. So these are the two conditions I'm going to discuss with you. So let's start with the first one, tricuspid atresia. We may call it also TA, tricuspid atresia, but I prefer still to use the word TA plus VST as in the past. You see, the 1% congenital heart defects at birth is quite 1/7 of the conditions on the left side. So if you take the typical left heart diseases, coarctation of the aorta and hypoplastic left heart syndrome, you have each 7%. So we have 15% of left-sided obstructions versus 1 or 2% on the right side. So it's by far less common. Before I continue, I want to show you a case. This is Angelina, 24 years old. I met her 2022, and this is her son after birth. And we'll tell you the story at the end of my presentation because it has to do with this situation. So tricuspid atresia has a typical feature of an atretic tricuspid valve orifice. There is a VSC which can be small but a bit larger, and it's associated with a small right ventricle due to the lacking of inflow. So the right ventricle is filled solely via the VST, and this is why it is related to the size of the VST. The great vessels, when they arise from this heart, can be either typically concordant, that means from the left ventricle, the aorta, and from the right ventricle crossing over the aorta, the pulmonary artery, but can also malpose in parallel condition. In my experience, 20% of the cases, but in some studies, up to 40% of the cases. And generally, it's acknowledged that the vessel arising from the small right ventricle is narrow, so it can be associated with the right ventricular outflow tract obstruction. Occasionally, it can be associated with the cardiac or extracardiac abnormalities, but in the meantime, since we are doing more exome studies, I think there are new knowledge raising, but I will not cover this in my presentation. So this is one of many years ago, a specimen of a fetus we had after termination of pregnancy, and you see how the anatomical absence of a tricuspid orifice between the right atrium and the diminutive right ventricle with a large VST, and this is here the left ventricle. Now, this is here how in the four-chamber view it can be evident. So it is one of the typical conditions you discover when you perform a simple screening of the four-chamber view, because this is already abnormal with an obvious finding. Typically also for this condition, and this is, you'll find it very often, is a bulging of the foramen ovale, because the whole flow will pass through the foramen ovale. Conversely to the other condition with the pulmonary atresia, you may have some blood entering the right ventricle and coming back. So in this, such a typical picture, and if you get to the ductus venosus, you have often a reverse flow in the ductus venosus from the first trimester onward, but also the second trimester, without the impending danger of having an hydrop. So this is, people ask me sometimes why. I said probably the cases ending in hydrops will have died at 10, 11 weeks, and we don't see them, and the one continuing with pregnancy are the one who succeeded to get into the second and the third trimester. These are the different pattern or spectrum, but what you see here is as soon as you see a small right ventricle, it's almost very often related to the size of the VST. So the larger the VST, the larger we'll have the right ventricle, because the quantity of blood will enter to the right ventricle depends on the quantity passing through the VST. So you see, if you have a very diminutive VST, you have very small right ventricle. And there are, of course, conditions where you don't have a VST and you don't see any right ventricle, but they are quite rare in general. And this is here an example. You see here, this is the right ventricle, this is the VST, and this is here on the video clip how it appears. You have the impression that something is moving here, but This is an echogenic thickened apparatus, kind of remnant of what would have been a developing tricuspid valve, but always closed. With color Doppler, it's quite interesting because it has a typical pattern. The typical pattern is the blood flow will enter from the superior and inferior vena cava to the right atrium, will cross through the foramen ovale. I told you the large foramen ovale will go into the left ventricle and then makes a turn at the apex of the left ventricle along the septum, getting a bit into the right ventricle, but also in systole to the ascending artery. Let's in general is the aorta, but some part will go to the right ventricle. So I'll show you in this one step by step. So this is here the grayscale image, and early diastole you have the filling of the left ventricle. Then the next step you will have in late diastole, you have the blood getting from the left ventricle across the foramen, the VST into the right ventricle, and then in early systole, the blood will go to the ascending aorta in this case, and some blood will go from the remaining right ventricle to the, in this case, to the pulmonary artery, and this explains why the vessel arising from the right ventricle is rather small, and often you may have pulmonary stenosis in these cases. And this is here a video clip showing you how the blood will enter. So keep in mind, this is a left to right shunt, and mainly in late diastole, leading to the filling. And you have some acceleration of blood across the mitral valve because you have double quantity of blood as in normal fetus expected, because there is no blood going to the across the tricuspid valve because it's closed. Now, there are some classifications. One of the classical one is the type 1 and type 2. The type 1 has a normal vessel origin, and the type 2 has a malpose or detransposition of the great vessels. There is a type 3 where they put the 1, which did not correspond to neither 1 or 2. In general, you have other malposition. You may have a common trunk or other things. And then there is a subclassification in A, B, and C. In general, A being the pulmonary atresia, often associated with an almost non-visible right ventricle, pulmonary stenosis, which is the most common one, but also a patent normal-sized pulmonary artery. But keep in mind, if you see it at 20 weeks, this pulmonary artery may become a bit stenotic at the end of gestation. Now, the question is, in this drawing taken from this book of Michael Hofbeck from Tübingen in the past, I'm not sure if it's correct, because I know that cases where you have malpose vessels, in general, the aorta will be the one getting diminutive. You may have aortic coarctation, you may have aortic atresia, and you may have also patent aortic artery. But anyway, so we have type 1, type 2 divided into A, B, and C, and this is the most common one. You may see probably is the type 1B, which means you have a VST, you have a small right ventricle, you have a concordant crossing of the vessels, and you have a narrow but patent pulmonary artery. And this is how it looks like when you have a video. You see the narrow pulmonary artery with the comparison to the aorta, and this is here how it looks like. So you see from the right side, the small right ventricle, the aorta arising from the left, and the narrow pulmonary artery. Now, if you add color, you will see the antegrade color, and look at this shape of this image. I'm sure neither Simon nor Julien nor me will recognize that this is from a tricuspid atresia, because the pattern is the same what you have seen as the Y sign in the cases of tetralogy of Fallot. These are typical of so-called pulmonary stenosis in the context of a presence of an VST at the level of the heart, because you have less blood getting there. And if you measure velocities, you may have some slightly increased, but also some normal or even lower peak velocities. So the peak velocities is not of big importance in comparison to the shape and the vessels. And if you look at these images, they did not develop first at 22 weeks. This is why even in early gestation, you may have this picture of these vessels. So this is why, again, play up for support for looking to the three-vessel trachea view in early gestation, because you may discover that earliest this kind of condition. So this is tricuspid atresia with pulmonary stenosis. But I told you again, the type C can be with pulmonary atresia. So this is how it looks like. You have a single vessel on 2D. You hardly see anything like pulmonary artery. And with color Doppler, you see the solarly reverse flow across the arterial duct getting into these tiny vessels and having retrograde perfusion of the lungs. These children are of danger of getting cyanotic just after birth, while with pulmonary stenosis, there is a good chance that they have a normal course after birth, even getting home without the need of surgery in the early days and weeks of life. The other case, as I told you, is related to a parallel course of the vessels. So this is the transposed condition. You don't see them on the four-chamber view, but getting to the great vessels, you see that this aorta is more anterior to the right side of the pulmonary artery. And the case you saw before, this one here, has a VST with a small right ventricle. And you see here, this is the case. And getting to the great vessels in systole, then you will see that this is showing the parallel course of the two great vessels, and this is the pulmonary artery with bifurcation, while this is an aorta, and the end of the aorta is probably narrow, could be an impending coarctation. So we will warn the cardiologists that after birth they should consider this, but it will be decided clinically after birth. Here again, the same heart with this way, and then with the stick showing in the background the tricuspid atresia, but also the course of the vessel, how they had a parallel course. What about early gestation? The study of Minella, but could be also the Singilaki paper, analyzed the 100,000 pregnancies with normal chromosomes. And interestingly, the heart anomalies detected early gestation were 50%. Almost all tricuspid atresia and pulmonary atresia were discovered in early gestation, in comparison to transposition or tetralogy, where only 10 to 40% of the case. So in other words, if you use 2D or color Doppler, you should get into the picture of having an abnormal four-chamber view, even in early gestation. And especially when you add color, it's quite easier in comparison to 2D. 2D is sometimes challenging. In my experience, more the disproportion of the ventricles which be first apparent. And you will see in the cases of pulmonary atresia, sometimes the right ventricle is quite small, but you have difficulties in comparing a normal small right ventricle to the true small ventricle. Because, you know, the right ventricle is by definition a bit smaller than usual. And sometimes at a moment you are not sure, is it really smaller than the one small chamber I'm used to see? But when you add color, there is always, in both cases, in both conditions, of small right heart and abnormal color Doppler. And this here again, a similar case at 17-week gestation. And if you go earlier, another case at 15-week gestation showing you the same pattern. You see the filling here. I reduce the velocities in order to get the flow to visualize the flow to the right ventricle via the VST. And again, the typical picture of a narrow pulmonary artery along with the left superior vein cava in this fetus, and this is the case at the 12 weeks of gestation. You see, first of all, I have not seen the right ventricle. It appeared only as a left ventricle seen here, but then with color Doppler, I could demonstrate this, and the three vessel tachia view were evident. Now, pitfalls. Well, I love pitfalls. I love mistakes. When I was young, of course, no, but now, because this is mistakes where you learn from. And I often say in life there are no mistakes but only lessons. In this case, after a scan, after 1 minute, said, I know it is tricuspid atresia because it looks like a tricuspid atresia. I've seen some 50 cases, and you think it's tricuspid atresia, and you switch the color on because by routinely you switch the color on, and I discovered I was wrong for a minute, luckily only for a minute. So, and then if you look at the foramen ovale was not bulging that much, but what happened here is, sorry, give me a second, is this condition. Because this is the double inlet ventricle, and the valve was not closed, but this part of the valve appeared as it's closed, and the valve was opening into the left ventricle, and this is double inlet left ventricle. And if you look at the video clip here, this is how it appears. So on 2D, you have the impression it looks exactly like a good right ventricle with a large VST, but this is a patent valve, and you see it only on color Doppler. So keep in mind, always switch the color on. If you assume it's a small right ventricle, but this is not a typical right ventricle. This is the bulboventricular outflow region in this double outlet ventricle situation. So keep in mind, this could be one of the interesting differential diagnoses. What about the outcome? I took this study from Christoph Berg on tricuspid atresia. In their studies, in their series, they had analyzed some years ago 54 cases. 52 had concordant and 45 discordant cases. In the literature, in general, it's more like 80 to 20, but nevertheless, detection age between 12 and 32 weeks of gestation, the mean or median was at 22 weeks. And then associated abnormalities was in 22% of the cases, so like factorial association or even chromosomal were found in these studies. So it could be today with the exome a bit more, but sometimes could be also less. Interestingly, that because of single ventricle anatomy, some patients decide to stop pregnancy, but all in all, this is a condition where it has an acceptable good outcome. Because you see 80% have operation and survival. Why I say acceptable? You see here from different studies, the surgery and survival depend on associated extracardiac findings, of course, anatomy of the great vessels, and severity of the outflow tract obstruction. So the type 1B may go home without need of surgery. So because what you have here in comparison to the hypoplastic left heart syndrome, if you are getting at the end into a single ventricle surgery, you have always the left ventricle, which is responsible for the whole body, which is different from the hypoplastic left heart, where you have a right ventricle prepared to be the main ventricle, which has less, let's say, a good outcome. So, and you see here the survival rate is between 80 and 90% and even more. So let's come back to my case. This patient came and she said, you don't remember me, but you should remember me. And her father came with and said, you don't remember us, but we were with you many years ago, because his wife has an ASD, and she came for me to scan them, and she had a tricuspid atresia. And I found in my archive her image. She was the same age of my son. It was 98. I remember they had the case because her last name is quite so rare. And they were grateful that I did well counseling, but I'm sure that I did not counsel positively. 98, univentricular heart Fontan procedure was not, let's say, these great operations success. And but you can give her a chance, but see, my wife has a cardiac anomaly and she's okay. Okay? But there is one chamber missing here in these cases. And he remembered that I was positive in my counseling. I don't remember I was positive because in these cases at that time it was not the case. But nevertheless, I remember him very well because he came once. He said, in 2 weeks from now, I need from you a discount. He came to visit me in the delivery place. Why? I said, my wife is getting an operation now, and my daughter will be operated, so we need a discount because 2 operations in one family. This is why I remembered him very well, because if I could, I will give you a discount. Anyway, so this is Angelina. She survived, single ventricle. She was pregnant. She delivered a healthy baby, and then that's it. So this is why today we should be more optimistic, because this was 22 years ago. Now, when we see the small right ventricle from our book, what can we do? We at coronary Doppler, if there is a VST, yes, it could be attenuated tricuspid valve, and this looks like no filling across the absence of the valve. The diagnosis of tricuspid atresia with VST, then you will get into one of the great vessel arrangement. Either they are normal, this is type 1, or they are in demalposition type 2, or they are in the complex abnormality like L malposition or common arterial trunk. This is the other group. Now, if you don't see a VST, the next condition could be associated with a tricuspid regurg or a small filling of the right ventricle. Then think of the condition called pulmonary atresia with an intact ventricular septum. And this is the next condition we will be discussing now. So this is how we are reasoning in our mind. So you see a small chamber, you add the color, and you get into yes or no. And the next condition to discuss now is pulmonary atresia with an intact ventricular septum. So this condition is also rare as a 1% of the condition. You see, it looks actually like an hypoplastic left heart syndrome, but on the right side, a small ventricle. We don't have endocardial fibrinostosis, but we have a small ventricle. We have valves, you can see them, so be careful before pretending they are closed, the valves. And the reason is an atretic pulmonary valve. And the valve here, the inflow valve, is dysplastic because the flow gets in but does not get out to the pulmonary artery. But in 30 to 40% of the cases, you may have the combination with ventriculo-coronary communication. That means, I'll show later on the images, you will have some coronary arteries connecting this right ventricle with the aorta, with the coronary system of the aorta. Occasionally, it's associated, but as I told you with the other case, we have more and more experience that it's more commonly the case than we assume. So the typical picture is a short right ventricle, but as I told before, under normal conditions, you may not see this quite clearly. You have the impression the left ventricle is quite larger, but the mean sign I'm using is the bulging of the septum toward the left side of the heart. And this here, how it looks like, I put an asterisk on this, and you see this bulging due to the more likely circular shape of the right ventricle in these small cases is an obvious finding. And you see here on this video clip how it looks like. You see a non-contractile right ventricle, a quite short right ventricle, a slightly dilated left ventricle, and this is the first impression we see. By adding color Doppler, there are 4 findings you may find. One is the complete absence of flow, like this one. Another one, you see some filling of the right ventricle. The third color Doppler sign is a severe tricuspid regurgitation, or another 4th sign, you may see in the region of the wall some communication with the coronary system. So these 4 signs. First sign is this one, could be here, absence of any filling. It depends on your color Doppler setting. This one, you see some filling of the right ventricle, similar to what you see sometimes in hypoplastic left heart syndrome. You see some filling, but you see a mitral regurg in the other group. And this is here a video clip showing you what I mean. And sometimes you see in the same fetus both. It depends on the preset you are using color. If you are using high velocity, very high, you may not see the tiny filling. If you add a bit colored up, you see the filling. If you put sample volume there, you have often, especially in such severe cases, a single inflow peak instead of the double peak, like with the 2 E and A waves. And this is the other way when you see a small right ventricle with an echo. Tricuspid valve, you see the filling, but you see also the severe tricuspid regurgitation as shown here. And from this moment, you start having difficulties in getting to the diagnosis. Is it purely pulmonary atresia with intact septum, or is it already a tricuspid valve dysplasia? And there is a continuum between both. So I cannot give you a true answer what is the end, and because sometimes you have the impression that tricuspid anyway dysplastic here, and you may call it tricuspid dysplasia, which is my talk tomorrow. But anyway, so this is the good way. Actually, we think it's a bad sign, but actually it could be a good sign because the ventricle shows that it can still contract very well. And this is here the flow I showed you, I discussed. You have a monophasic inflow, but you have a severe regurgitation. And if you are using a CV Doppler, you will have documentation like showing this one with peak velocities in the tricuspid regurg up to 350 centimeters per second in a closed pulmonary valve. Getting to the three-vessel view, you see what you are expecting to see. The pulmonary artery is narrow in compared to the aorta. In general, you know that pulmonary artery is at least the size or slightly larger than the aorta. In these cases, you have this like short axis or three-vessel view, the narrow pulmonary artery. Getting to the three-vessel and trachea view, you will demonstrate the reversal flow, which is mandatory to be found in these cases. And again, look at the shape of the vessel. It's like a Y sign because the pulmonary artery is entering on the side of the aorta in these cases as well. Sometimes you may have difficulties in getting to this view, so you turn the probe in an almost sagittal view to show this reversal part in the diastolic arterioles, which is confirming your diagnosis of pulmonary atresia with intact septum and reversal flow. This was the isolated cases. What about the next group, which is told you 30 to 40% of the cases? Here, look at in this region here, what you have here in comparison to this one, you have a connection between the right ventricle and the coronary system. And we are not sure if this is secondary or this was primary, because in the early embryo heart, you have these communications in a kind of spongious myocardium. And there is a theory that this can be the primary disease leading to a less flow across the developing pulmonary artery and leading to this to persistence of these vessels. But this is another story. Another story was saying, yeah, it is probably due to the high pressure in the ventricle leading to these sinusoids. But we have reported in 25 years ago on a case I detected at 13 weeks gestation, and I said that time to the embryologist in Holland, and she said she believes it's still the primary lesion, with evidence that it was seen early in gestation. Anyway, so this is another story, but what you see here is on the wall of the right ventricle, you will have some color Doppler signals, and if you add sample volumes there, you see flow from the heart, from the right ventricle into the system and back into the ventricle. So the flow will go from the right ventricle into the ascending aorta, but in the systole, it will go back into the right ventricle. So you'll have bidirectional flow, and it's not like what you assume it could be pericardial fluid, because pericardial fluid would not have high velocity like this condition. So this is the presence of ventricular-coronary communication. The problem is that we assume it has a very bad outcome, but it's not true. But they cannot in general be corrected with biventricular repair, because you cannot cut these here. They are quite difficult because they are related to the coronary system. So this is why, and you cannot do also an opening of the pulmonary valve. Anyway, the question is, you see here again, the difference between these cases and the other one, they have a tricuspid regurg. If you don't have tricuspid regurg, but a flow entering into the right ventricle, keep in mind, it should go somewhere. If it does not return back, it goes to the coronary artery. So seek for them when you have a bit of filling here, and you will continue to see at the apex and on the outer border. And this is also called VCAC, going into the ascending aorta, and this is the flow into the other direction. So it can be demonstrated even early gestation. Pulmonary atresia, intact septum can be seen early gestation. 13 weeks, you have here regurgitation, you have a reversal flow like you are expecting to see in the second trimester. This is another case I saw last year. The mother is diabetic, and we did not find anything on exome, so it could be the reason. You see the small right ventricle, the bulging into the left ventricle, absence of flow, and you see here the reversal flow. And here on the border of the ventricle, these vessels with the bidirectional flow, and this here on color Doppler. And it's with these velocities, you still see the bidirectional flow in this case. A quite interesting study I saw recently, some months ago, is this one. The patient was referred with a thickened nuchal with a cystic hygroma, small right ventricle. And the colleague told me, should I do invasive and exome? I said, of course, because what we do is when we are sure it's a complex cardiac malformation, we try to finish exome sequencing until 16, 17 weeks. And then when everything is normal, then we discuss with the cardiologist on counseling. Because if you wait to have a counseling, and you wait, and in 20 weeks you get your exome, and then, so what for? There are few exceptions when you have some ventricular disproportions where you may not sure at the end it's going to be cardiac anomaly at all. But if it's something like so here true, I think it is worth doing it. And what you see here, this fetus was the presence of an ARSA, which is quite interesting. And this had also the VCAC I told you before. So this is here on the border of the right ventricle. Why ARSA is important? Because it can turn the direction of this diagnosis. And guess what it was at the end? It was a Charles syndrome. So I could not follow to see what happened, because she decided anyway to terminate pregnancy because of this complicated cases. But the presence of an ARSA may have increased the risk, because many people do not know that Charles, they have 20%, they have an aberrant subclavian artery or aortic arc anomaly. So if you know the combination, you may think, okay, it's unlikely to be 2211, but we discussed this one day later, because you can do the fish on next day with the 2211, but it turned to be a Charles syndrome. So it was worth not waiting until confirming 16 weeks, having amnio, and confirm at 19 weeks. So different diagnosis in these cases can be a small right ventricle, can be a critical pulmonary stenosis, but in this case you have an antegrade flow across a pulmonary artery. It can be pulmonary athesia with VST because of the reversal flow, but in general you will see an overriding of the aorta in these cases. And pulmonary athesia, they have rather MAPCAs. Epstein anomaly, tricuspid dysplasia. I told you about tricuspid dysplasia. Sometimes it's not easy to make the comparison, but you will or to differentiate this. But some of the tricuspid dysplasia, they have also pulmonary athesia, and it depends at the end what the right ventricle is doing. And last but not least, it can be tricuspid athesia, but I hope I showed you the difference in my talk. So open questions I will not address in my talk today are some cases of severe pulmonary stenosis may develop into pulmonary athesia. We know this, like what Alberto showed from the aortic stenosis to aortic atresia to hypoplastic left heart syndrome. This is why there are in these cases also a rationale for doing fetal intervention, valvuloplasty, to open the pulmonary artery. But many people are saying it's not worth because the case you will do intervention are the one who are very good also for postnatal biventricular repair. And some newborn with pulmonary athesia may have biventricular repair. Conversely to the tricuspid athesia. Tricuspid athesia, they have one chamber at the end. They cannot have two because there is no tricuspid valve. But there are cases where here you may have a good chance that the right ventricle is still well working, and the shape of the right ventricle has three parts, an inflow, a ventricle, and outflow part, and there is a good chance that you can open the pulmonary artery valve, which is athletic, in order to get a good functioning right ventricular heart. So this is why it is worth some of these so-called small right ventricle may end up biventricular. But keep in mind, is it really easy to have a counseling 22 weeks to tell them, I'm sure it's going to be biventricular or monoventricular. So outcome depends at the end on, it can be very good to bad, because, you know, if you have an atresia of one of the great vessels or an aortic atresia in parallel course, it's also bad. It can be associated findings, as I told you before. You can perform perforation, you have a biventricular repair or univentricular repair. And in our book, we put a criteria of poor prognostic findings in the literature, like severe tricuspid regurgitation, if it's not leading to a huge heart, but an acceptable, as the case I showed you, could be a bad outcome, but some will also rescue the ventricle. But look at the small tricuspid valve annulus. If you have a Z-score smaller than -3, it could be bad. If you have a small right ventricle to left ratio, of course, a bad outcome, and the presence of fistula and presence of associated cardiac or extracardiac malformation. Let me sum up. In summary, I showed you today two conditions have a small right ventricle, one with an inflow obstruction with a different spectrum, type 1 and type 2, and the other one with the outflow obstruction, pulmonary athesia with intact septum, showing you the range of possible outcome and association with other anomalies. And in our book, we put a table because you are first confronted with the small right ventricle, how to distinguish between both. You will see one, I need to put my glasses, so right ventricle is always athletic, but you may have some where have a normal size or dilated. The right ventricle wall is normal and it can be hypertrophic. The septum, you see septal defect, but you see the bulging into the left ventricle. Foramen ovale is large, huge. It has a normal foramen ovale despite having a right to left shunt. The tricuspid valve is thickened. Here it is dysplastic, but occasionally you may see also movements of the valve. The right atrium is of normal size but can be dilated due to severe regurgitation. Pulmonary artery, patent valve, rarely athletic, but here you have, by definition, athletic valve and narrow pulmonary artery. The flow in the ductus is in the typical type B, pulmonary stenosis, generally antegrade, but you will have always retrograde in pulmonary athesia. And last but not least, the vessels can be concordant in most cases. Here in pulmonary athesia, it's always concordant. And postnatally, these children with pulmonary athesia are always cyanotic, while the other one, they may go home if they have a narrow but patent pulmonary artery, but sooner or later they will need surgery and corrective, as you saw in the patient I showed you. So this is why these are my summary slides, and I finish my talk by thanking you for your kind attention. Thank you.